Okay, so today we're doing the second part of the glass ionomer cement lecture, and we are going to learn about the mechanism of adhesion. So as we have already done, it's the only cement that is providing chemical adhesion to the tooth structure along with polycarboxylate cement. The polyalkylate cement, the COO group, the acid and the H plus ions are released, which attack the enamel and dentine and displace the calcium and phosphate ions. They migrate into cement and develop an iron-enriched layer firmly attached to the tooth structure. The bond structure to enamel is always higher than that to dentine because of the greater inorganic content and greater homogeneity. So what is a mechanism? As suggested by various researchers, it is the chelation of calcium ions or interaction between the apatite and polyacrylic acid to form the polyacrylate ions, ionic bonds with calcium ions in enamel and dentine. So here we can see the cross-linking which is taking place at the junction between the tooth surface and the newly based glass ionomer cement. The CO minus group present in the polyacrylic acid is reacting with the calcium and the phosphate ions and everything else present in the hydroxyapatite surface. So there's always an interdiffusion zone or the ion enrichment zone where the exchange between the glass ionomer cement powder and the tooth structure is taking place. The bonding is similar. It is through the formation of the cross links with these calcium and aluminum ions along with the COO groups of the tooth structure. And additionally, there's a bonding to the collagen of dentine through hydrogen bonding or metallic ion bridging between the carboxyl groups on the polyacid and the collagen molecules. So not only the chemical adhesion, it is also having some amount of hydrogen bonding and the together so that we can now go to the characteristics of glass ionomer cement. So glass ionomer cement forms a rigid substance on setting. It has a low exothermic reaction, no polymerization shrinkage, no free monomers present, dimensional stability and high humidity, filler matrix chemical bonding, fluoride release, good bond to enamel and dentine, and early moisture sensitivity, which requires protection immediately after placement. So what are the physical properties? So these properties are calculated for the recommended powder liquid ratio. The working time is 2 to 3 minutes. Setting time is 6 to 9 minutes. Solubility is 0.07% by weight. Pulp response is better. And it is anti-carcinogenic, yes. Coefficient of thermal expansion is very close to that of dentine. That is why it has been called as man-made dentine. It is undergoes similar changes in dimension. Opacity is 90%. It has poor wear resistance. So when we are using it as luting thickness, what happens is the strength properties are a little on the lower side because the powder content of the mix has reduced and there's more amount of the liquid which has been used. The viscosity is less. So the elastic modulus is approximately 7.3 and the pulp response is mild to moderate. The comparison between the traditional glass ionomer cement and the reinforced cement as we know it, metal modified cement and resin modified hybrid cement. Okay, then thermal properties. Thermal diffusivity value of GIC is close to that for dentine. That is why it has been called as man-made dentine and or the substitute of the dentine, and it has been used as a thermal insulative material on the pulp and provides it from thermal trauma. Solubility and disintegration lower Then zinc phosphate, zinc polycarboxylate, that is the gold standard in water. It is less than silicate cement. Now, there's no point in comparing with silicate cement. This is only for theoretical purposes. That wear resistance is less than composites, hardness is less than silicates, tensile strength is almost comparable, compressive strength is greater. Aesthetics. Glass ionomer cement has got a degree of translucency because of its glass color. Unlike composite resins, glass ionomer cement will not be affected by oral fluids once it has been set or it has reached the post-gel maturation phase. Now, biological properties. Two main biological properties include biocompatibility and anti-carcinogenic potential. That is, one, we have to see the response of the pulpal and the periodontal tissues, and second is the anti-carcinogenic property. Biocompatibility is resistance is due to release of plaque from release of fluoride. The pulp response to GIC is favorable. Freshly mixed, it's very acidic. Mild inflammation, but soon the pH value reaches about 6 to 7. Glass ionomer cements have to be in direct contact with dentine. That if you put a layer of varnish or any other bonding agent in between, then the intimate chemical adhesion will not take place, nor the fluoride release will happen. So clinical experience has shown that adverse effects of glass ionomer cements on living tissues are minimal, so that the protective liners are rarely required, and you can directly use as a liner or a base filling material in case of the sandwich technique. Their addition to tooth material ensures that they provide an excellent and enduring marginal seal, thus eliminating secondary decay. With sustained release of fluoride confers resistance to the adjacent tooth structure also. The fluoride will get incorporated in the adjacent tooth structure, and that will also lead to formation of fluorapatite. So effect on pulp and cells. Glass ionomer cement causes greater inflammatory response than zinc oxide eugenol cement, but less than zinc phosphate cement and related dental silicate cement. The inflammatory response of pulpal tissue towards glass ionomer cement resolves within 30 days, and there is no enhancement or of reparative or secondary dentine formation. So we have seen that it is more biocompatible as compared to the zinc phosphate cement or zinc polycarboxylate cement. Why is this? Because the acrylic acid, which is used as a weak acid, it has a higher molecular weight, so that it will not be diffusing very rapidly through the dentinal tubules, and it has a larger molecular size. So this is how the cross-linking is taking place between the COO minus groups and the calcium in the tooth structure. Even when the bulk of the glass ionomer cement fractures or is lost, this iron-enriched layer or the bonded layer is attached to the dentine and prevents any hypersensitivity from happening. Then we have fluoride release. One of the most important properties of GIC is that of the release of fluoride ions throughout the life. This fluoride again prevents a karyostatic effect. The influence of fluoride is in a zone of resistance to demineralization, that is approximately 3 mm around the glass ionomer restoration which has been placed. Now, the release of fluoride takes place over a period of 18 months. The rate of release is initially faster and then gradually lessens with time, and thicker the mix, more is the powder content as compared to the liquid content, more will be the release of the fluoride. So there's a rapid early release of the fluoride from the resin matrix, and later then there'll be a slower release by the way of diffusing. So enamel solubility is reduced by this process of fluoride release and uptake as fluorapatite is formed. Consequently, the incidence and severity of recurrent caries are reduced. Fluoride contributes to the caries inhibition in two ways. One is physicochemical inhibition, which is the more mere resistance to acid decalcification. Caries enamel is more porous than sound enamel. This porosity allows increased penetration of fluoride, which contributes to the formation of acid-resistant crystals and reduces the risk of caries development. Then we have biologic mechanisms. It inhibits the carbohydrate metabolism of the acidogenic plaque microflora. Fluoride enters microorganisms against a concentration gradient and accumulates intracellularly as the extracellular pH reduces. The transport of hydrogen fluoride into the cells leads to dissociation into H ion and fluoride ions within the more alkaline intracellular fluids. Ionic fluoride then causes enzymatic inhibition and leads to slower rate of acid production. So it is acting on the plaque or the biofilm which is there and limiting the amount of acid which is being formed there. And simultaneously, it is working to reinforce the tooth structure by forming fluorapatite. Now, this is about the fluoride movement cycle of fluoride recharge. So whenever you have placed the GIC over a tooth structure, there will be an initial peak of the fluoride release. After a few months, it will stabilize. Then it will deplete, or the amount of fluoride available will be reduced. Then only on the internal surface it is available in this depleted state. Again, if you apply a fluoride varnish, then that fluoride varnish application helps in recharging the fluoride content which is there in the matrix, and later on the fluoride cycle can continue. Adhesion, we have already done that. The bond is of chemical nature. 80% the bond strength is obtained within 15 minutes. The bond strength to enamel is always higher than that of dentine because enamel has a more homogeneous structure. In the what will be the indications: restoration of class 3 and class 5 carious lesions in the aesthetic zone, repair of defective margins of the restoration or temporary coverage of fractured teeth, pore buildup, sealing of the root surface for overdentures, eluting cements will have a film thickness of approximately 20 to 25 micrometers. There will be a finer particle size for this because whenever you're using as luting, there will be limited powder and higher amount of liquid there for a luting cement. So even the chances of pulpal irritation will be more. So glass ionomer cement has all been proposed as a bone cement in case of surgical procedures. Then we come to the cement placement. For cement placement, first step is to prepare the substrate where we have to place the restoration. So we have to partially remove the smear layer so as to expose the underlying dentine surface. So surface conditioning was first introduced, or the term was introduced by McLean and Wilson in 1977 so as to differentiate it from acid action. The smoothing of cut dentine and laminate surfaces may be a mechanism whereby surface conditioners improve adhesion. Good interfacial contact is important for adhesion. The smoothing of surface irregularities may be necessary to prevent air entrapment and to minimize sites where stress concentration could occur. Now we have polyacrylic acid. 25% is the solution which is recommended for removing the smear layer. Polyacrylic acid, if anything is left behind, then it can incorporate into the matrix of the cement later. Other than polyacrylic acid, what can be used? 50% citric acid can be used. Then active surface microbicidal solutions such as tublicet contains chlorhexidine, gluconate, dodicin, surface active agent, which will reduce the surface tension and help in spreading. And 3% sodium fluoride strengthens the bond to enamel and dentine. Then you have more surface conditioners, which is tannic acid. They'll do is remove the smear plug and slightly modify or dissolve the smear layer. Then we have EDTA. It is a weak acid and insoluble in water. Then we have to make it water soluble, there are sodium salts which are used. Sodium by EDTA and similar salts are used. Both are strong decalcifying agents because of strong chelate they form with calcium, but they reduce the bond strength of glass ionomer cement. 10% aqueous solution of polyacrylic acid is most commonly used for this conditioning. So how do we manipulate? The powder liquid ratio recommended by the manufacturer should be followed because any reduction in the ratio of the cement adversely affects the properties of said cement and its susceptibility to degradation in the oral environment. For mixing, we need a glass slab or a water impervious paper pad so that it is not absorbing the water in the glass in the bottle of the liquid, and then it does not alter the water powder ratio. High temperatures may alter the working time. Also, temperature should not be below the dew point because Condensation of water that occurs, then again the amount of the um, if the liquid is exposed to the environment for a longer period of time, the moisture content will reduce. So the powder liquid ratio will change. The powder should be incorporated rapidly into the liquid using a stiff plastic spatula using the folding technique. Plastic spatula is used because cement sticks to the stainless steel instruments. And because of the glass particles there, it can lead to scratches on the surface of the cement spatula. So how it is to be done, shake the bottle lightly so that all the faces are uniformly distributed. Remove the excess, take the recommended powder liquid ratio to prevent bubbles from coming into the liquid. First, the liquid bottle is held horizontally and then the requisite amount of liquid is dispensed. Then the powder is divided into majorly two increments, where the first increment is folded into the liquid in 10 to 15 seconds. Second half is incorporated in under 15 seconds using a small mixing area. Because the reaction is not exothermic, there's no heat to dissipate. So it is just the intention is to wet the powder particles. So this is the armamentarium and steps. The mix should have a glossy surface, which indicates that there is free carboxylic acid groups present, which ensures a adhesive bonding to the tooth. If mixing is prolonged, the dull surface will develop and adhesion will not be achieved. Then how do you decide which consistency? There are two consistencies, luting and lining, or the restorative consistency. So luting will be like a stringy consistency, and the other consistency that I talked about will be in the form of a ball-like or putty-like consistency when it is being used for the restorative purpose. Working time for GIC 60 to 90 seconds. Resin modified is 3 to 3.5 minutes. Setting time, it says rapidly in the mouth. That is within 3 to 5 minutes, and it has a kind of translucency that matches the enamel. So glass ionomer cement can be supplied in the form of capsules, and to activate the capsule, we have to first break the diaphragm, and then it has to be used in the amalgamator, say approximately 4,000 cycles or 3,000 cycles per minute speed. So finishing and polishing and placement. Placement is the application of direct restorative material, the selection of shade and restorative material, tooth isolation, preparation, and restorative bonding. Everything has been done. The preparation has been modified, surface conditioning has been done, and now it is ready for receiving the restorative material. What kind of matrices can be used? Class 5 clear matrices, metal matrices, mylar strips, metallic matrices, all of these have been tried with the glass ionomer cements. Carving the cement external to the cavity margins with sharp knives or excavators. Now you should not break it or pull it once the setting has taken place, because then the marginal integrity will be disturbed. So you have to cut it and remove it with sharp knives or excavators. Then after 24 hours, finishing and polishing can be done. What are the disadvantages of glass ionomer cement? It is a brittle material. That means the compressive strength is all right, but tensile strength is low. So it cannot be used in areas where tensile stresses or shear stresses are expected. Aesthetically, it is less pleasing than composite restorations, relatively opaque and lacks polishability, thus poor surface finish, technique sensitive, powder to liquid ratio and mixing. Then you have to protect it from moisture. You have to place it in the appropriate stage so that there is formation of a chemical bond. Powder liquid formulation alteration leads to reduced powder, physical and mechanical properties, decreased bond strength, prone to porosity, and a further cause of weakness. So water contamination during early stages of setting can cause porosity and solubility. Thus, GIC should be covered with a water impervious layer like varnish or dendine bonding agent once the placement or the initial set has been done. So the GIC is susceptible to dehydration over lifetime, poor abrasion resistance, contraindicated for class 4 or stress bearing restrictions, and poor acid resistance. So we can use it for various class 5 and class 3 applications, especially on the distal surface of canine. And if the surface is in direct, is not in direct vision when the person is at a conversational distance, and you can use these class inverse events for doing your class 5 restorations. Then what is atraumatic restorative treatment? ART was designed for developing countries, especially where the access to dental care was limited, and mechanized rotary instruments for removal of the tooth structure was not available. So ART was developed with the aim of sealing caries-prone pits and fissures and restoring cavitated dentin lesions with sealant restorations. So that glass annular cement, when it is present, it will help in minimizing further caries development. So it is one of the concept of minimal intervention dentistry, where only hand instruments are used to chip away and remove the unsupported enamel. And then later excavators will be used for removing the infected dentine, which cannot be remineralized. So tooth is isolated using cotton rolls. Access is made by breaking of undermined enamel. After removal of soft demineralized dentine by excavation, then you can restore it. So these are some of the cases which have been treated by placement of the glass ionomer cement. It has good biocompatibility. So even when the cavity is closer to the pulp, you can place the glass ionomer cement as a independent restorative material or in association with the sandwich technique. Okay, so sandwich technique is also called as the double laminate technique or the bilayer technique. It was also given by MacLean and Wilson in 1977. In this technique, both cement and enamel are etched prior to the attachment to a light coat composite resin. Now, as compared to traditional GICs, it is more sensible to use resin modified glass ionomer cement in the sandwich technique. GIC is packed into the bottom of a cavity, in effect, to replace a lost dentine and allowed to set and harden. When it is hardened, it is acidized up to 15 to 30 seconds and then using phosphoric acid solutions. This treatment results in rough surface in which the glass particles are exposed out of the matrix. A thin liquid of the resin is applied so that it penetrates in between these irregularities, and then composite resin is subsequently packed into the cavity. Advantages: polymerization shrinkage is less due to reduced bulk of the composite, favorable pulpal response, chemical bond with the tooth, anti-kerogenic property, better strength, finishing, and aesthetics of overlying composite resin. Micro leakage is reduced, minimalization of number of composite increments, therefore the time is saved. So this is a closed sandwich technique where the glass ionomer cement is not exposed to the oral environment. So you can have an open sandwich and closed sandwich. When none of the surfaces of the glazed glass ionomer cement is coming into contact with the oral fluids, and that will be called as a closed sandwich. If some part of the glass ionomer cement is in contact with the oral environment, then that will be the open sandwich. You have now reverse sandwich preparations, which are used in cases of invasive cervical resorption. So what will be the difference? That instead of glass ionomer cement being the first layer, then you'll have the microfill composite, and then you'll have the RMGIC on top of it. So this is a kind of a reverse sandwich technique. Then you have tunnel restorations. Tunnel restorations are again a type of conservative cavity preparation in which the marginal ridge is not involved in preparing the class 2 cavity. An approach is taken from the triangular fossa towards the marginal ridge or towards the lesion which is there on the proximal surface. So the preparation joins an occlusal lesion with the proximal lesion by means of a prepared tunnel under the involved marginal ridge. So when can we do it? When at least 2 to 3 mm away from the marginal ridge, the carious lesion has started forming and a significant amount of the marginal ridge stays intact. In this way, the marginal ridge remains essentially intact.